All right, let's jump right in. Today, we're breaking down a really critical topic for any clinician: how to spot and manage familial risk for pancreatic cancer. And this isn't just some academic talk, okay? This is a practical guide that can literally change patient outcomes in one of the toughest areas of oncology. So, let's kick things off with a number that really sets the stage. Somewhere between 10 and 15% of all pancreatic cancers are thought to have a genetic component. Now, that's not a tiny slice of the pie. That's a really significant group of patients where we have a chance to get ahead of the game. And, getting ahead of it is everything here. We all know pancreatic cancer is just notoriously aggressive. Most patients show up when the disease is already advanced and incurable. But this genetic link, this 10 to 15%, it cracks open a window for us. It gives us a real shot at early detection, a chance to find those precursor lesions or early-stage cancers and make a huge difference in survival. So here's our game plan for today. First, we're going to tackle the puzzle that is pancreatic cancer. Then we'll get into decoding the hereditary risks and figure out who needs genetic testing. After that, we'll walk through the high-risk screening playbook, and finally, we'll see the real payoff of taking this proactive approach. Okay, let's dive right into our first section. Pancreatic cancer is a true clinical conundrum, no doubt about it. But genetics. Genetics gives us a vital clue that we can actually follow. So when we talk about hereditary risk, it really falls into two main buckets. On one hand, you have these well-defined inherited genetic syndromes, where we know the exact gene causing trouble, like BRCA2. But then you have this other group called familial pancreatic cancer, or FPC. These are families that are just riddled with the disease, but we can't find one of those known genetic culprits. You got to be able to recognize both. Now, let's get into the nitty-gritty and decode the specific genes involved. These are the big ones, the high-impact syndromes that absolutely have to be on your radar as a clinician. First on our list is a heavy hitter, Peutz-Jeghers syndrome, PJS for short. It's an autosomal dominant condition, tied to mutations in the STK11 gene. And while it's often known for causing polyps in the gut, its connection to pancreatic cancer is just profound. And if you want to understand how profound, just look at this number. Patients with PJS have a relative risk of developing pancreatic cancer that is a staggering 132 times that of the general population. I mean, let that sink in. That's one of the highest genetic risks we see in all of medicine. Okay, next up is a syndrome you've definitely heard of, probably from other contexts: hereditary breast and ovarian cancer. Now, both BRCA1 and BRCA2 are involved, but when we're talking about pancreatic cancer, it's really BRCA2 that's the major player we need to focus on. If you're carrying a pathogenic BRCA2 variant, your relative risk for pancreatic cancer jumps up by about 3.3 to 10 times. And because BRCA mutations are relatively common, this is actually one of the most frequent hereditary factors you're going to come across in your practice. And another key syndrome you need to know is FAM, which is linked to the CDKN2A gene. The name kind of gives it away. It's tied to melanoma, for sure. But the risk for pancreatic cancer is also incredibly high, which makes recognizing this syndrome absolutely critical. For folks carrying a CDKN2A variant, the odds ratio for getting pancreatic cancer is huge. We're talking somewhere between 12 and 36. So here's a clinical pearl for you. If you see a family history with both melanoma and pancreatic cancer, a light bulb should go off in your head, and you should be thinking CDKN2A. So this is really the crucial point, right? We have all this incredible genetic knowledge, but what do we actually do with it? How do we translate that knowledge into action and decide which of our patients needs a referral for genetic counseling and testing? Well, this slide basically gives us a fantastic, actionable checklist. You're looking for things like known syndromes, specific family history patterns like two relatives where one is a parent, sibling, or child, or a diagnosis of hereditary pancreatitis. But listen, pay close attention to that guideline pearl at the bottom. This is the real game changer. Major guidelines are now saying that all patients diagnosed with pancreatic adenocarcinoma should get a risk assessment. That is a massive shift in how we practice medicine. Okay, so once we've identified a patient as high risk, either through their genes or their family history, our job's not done. We can't just stop there. We need a clear playbook for surveillance, because the entire goal is to find problems before they become incurable. In our screening toolbox, we've basically got two main players, endoscopic ultrasound or EUS and MRI with MRCP. And you can see here they're not rivals, they're partners. EUS is fantastic for finding tiny solid lesions. MRI, on the other hand, is way better for seeing cystic ones. That's exactly why surveillance programs often use them together, or they'll alternate them year to year. So, the big question is, when do we start all this? Well, this table lays it all out based on current guidelines, and you can see how the starting age is completely tailored to the specific level of risk. For a super high-risk condition like Peutz-Jeghers, we're starting as early as 30. For others, like BRCA2 carriers, it's more like 45 or 50. And for those familial pancreatic cancer cases, the rule of thumb is simple: age 50 or 10 years younger than whoever got it earliest in the family. All right, let's get to the best part, the payoff. Does all of this work, the genetic testing, the intensive screening, does it actually change things for patients? This is where it all comes together. I love this quote from the research because it just says everything, doesn't it? Stage shift. That's the entire goal right there. We are catching these cancers at stage 1, when they're localized and potentially curable, instead of at stage 4, when they're metastatic and terminal. And if you want to see what that stage shift looks like in real numbers, just look at this chart. It's absolutely incredible. The 5-year survival for patients whose cancer is caught during surveillance is a remarkable 73%. Now compare that to cancers found the usual way, after symptoms pop up, where the median survival is just a year and a half. This isn't just a small improvement, it is a complete paradigm shift. So to wrap it all up, what does surveillance really do? It accomplishes 3 massive things. 1, we get early detection. Most cancers are found at stage 1. 2, that leads to way higher rates of curative surgery, more than double actually. And 3, the end result is that profound, dramatic improvement in survival we just saw. This is real, evidence-based hope in a field that desperately needs more of it. And that really leaves us with a critical question for the future, one that we'll all be facing in our careers. As genetic testing gets cheaper and more common, we're going to get better and better at finding people who are at risk. The challenge then becomes, how do we use that power responsibly? How do we maximize early detection while minimizing the harm from overdiagnosis and unnecessary procedures? It's a tough balance, and it's one we're all going to have to figure out together. Thanks for joining me.